Hello, my name is Linda Gunn, and this session is going to be about looking at how we prepare the students for the clinic and also how we react to students when they're on the clinic. And I think that it's important that we remember to understand how students are actually feeling when they come onto clinics in order to treat patients for the first time, and not only for the first time but over a period of years that they'll be on the course with us. The students are going to change. They're going to change in their approach to the patients. They're going to change in their confidence in being able to come forward to us as teachers and as clinical staff to ask us questions about things that are maybe concerning them. Now, initially when students come onto the clinic, they'll be very wary of doing this in some cases, or some of them might be doing it almost too much because they don't want to get down to treating the patient themselves. So I think it's important for staff to just go back over this again and have a think about what we are expecting from students and what students are expecting from us, and also how we react to the students, particularly in front of patients if they happen to have patients that they're treating at the time. So we're going to go into this now, and first of all I'll just go over the learning outcomes, and then we'll look at it all just in a little bit more detail. And I've also included some comments here from students, just so that we can get a feel for what the students are thinking about how it feels for them to be on clinic, and the kind of things that they would like from us as staff, the kind of things that maybe aren't quite so helpful that we do as staff, assuming that everything's perfectly all right, but actually students maybe don't see it in exactly the same way. So let's go on then. So these are the learning outcomes, and just before I go on, just bear with me because every now and again I need to look down in order to be able to read the script off the slide. So if you feel as if I'm not looking at you or I'm looking down or away, it's just because I'm doing that. So the learning outcomes for this session are all listed there, and you can easily read these for yourself. But generally what we're looking at here is the times at which we interact with students, and I'm meaning by that prior to their clinical session, during their clinical session, and afterwards, and also looking at how we grade them. So I'll just give you a second or two to read through your learning outcomes, and ultimately what we're looking for is good practice and possibly some unhelpful practice as staff. Included in this presentation will be some research-based evidence, both in medicine and industry. We have to be very sure that everything that we are talking about to students is evidence-based. And the same goes for something like this, where I'm trying to give you instruction on what might be the best way to approach students on the clinic. And it's really important that we look at the evidence base from researchers that have done this previously. So rather than using anecdotal evidence that I would have from myself and from staff that I know who work with students, or the students themselves, we'll begin with some research-based evidence so that we actually have that grounding behind us. So the first of these is a paper by Lowe, and this is in 2015, so it's fairly recent. And while this is directed at nursing students, I think that some of the points that they raise are really pertinent to what we're looking at today. And they mentioned that the relationship that staff and students have really affects their learning. It's been attributed to the fact that clinical staff play a role not only as a teacher, but also as a counsellor, a coach, a mentor, and so very much more. And that they're involved in this transition of the students from being a novice or being a student into a student who's capable and competent to carry out the skills that we want them to do. It seems that from their research they found that 90% of the participants agreed that the support from the clinical staff did influence their learning. So we do have a really major role to play in this, and how we approach this is a really important aspect of it. They said that the support from the nursing staff can be a source of motivation, and that they feel welcomed as a student as part of the team. The clinical staff, however, need to recognise that students thrive in an environment where they feel respected and part of that team, and we have to create that environment to make it better for the students. Because anxiety levels of nursing students increase in the presence of unsupported clinical environments, and this inhibited their learning. And I think we can all understand really where they're coming from here. If they do feel supported and they feel comfortable in the environment, obviously they're going to learn better. So I've decided to look at when we actually meet with the students and the points at which we would be having interaction with them. And I've called these significant contact incidents, but you might call them episodes. And they're divided into this list that I see here. So it's almost a pre-task session, which I'm calling an initial clinical briefing. And then you go into the actual pre-treatment discussion that you have with your patient about what, the student about what they're going to do with their patient. Then there's a time when you delegate the task. And then while the task is going on, when staff can intervene during that task that's being undertaken, assessing the final task, giving the student a grade, and then finally what I would class as an end of clinic debriefing session, and this would again be with the whole group. So let's look at these. I consider that briefing sessions prior to a clinic are really important and really beneficial for students. I think it allows them to meet with the rest of their group prior to going into the session, and almost becomes like a huddle session where they feel a little bit more supported. And I think that all the staff that should be involved in this include not only the tutors, but any nursing staff that's working with the students that day, so that everybody has a feel for what's coming up and what we're going into, and there aren't any surprises, and everybody's quite clear about the expectations for the session that they're just about to go into. And if again we look at the evidence base that's out there, if we look at Wilson, they state that briefing sessions, whether they're individual or collective, give an opportunity for students to ask questions for their own reassurance rather than because they don't know anything about the procedures that they're just about to do. So it has to be seen as something that is positive. It's not a situation where the students are coming into and everybody's looking at them as if, well, you don't know what you're doing, because they do know what they're doing. But all this is just let's get to grips with what's actually going to happen to us all in this session that's coming up. They can, though, find that these sessions are a little bit threatening, especially if they don't feel quite as confident maybe as the others in the group, but they are informative for all, according to Wilson. They give the opportunity to learn from the other group members, and for other members of the group to be supportive of weaker members. Although we wouldn't pinpoint the weaker student, it's how they feel about being in that group prior to going into the session that's important. And if they feel supported by the group around them, not only their peers, the other students, but also the staff, tutors and nursing staff, then they'll go into the session feeling just that little bit more confident. And it's also a point at which the teacher or the tutor and the nursing staff can intervene in a positive manner to almost say to the student, okay, here's what's coming, but don't worry about it because we'll be there to help you. And it allows you to actually address any issues as far as that's concerned. It gives the opportunity to therefore identify unprepared, weak, or even failing students who may need help before being allowed to practice on patients. And it gives you a chance just to identify that and find out what they need from the session and how much support they're going to need to go into this session with a patient. At some point at the beginning of this session, the tutors are going to ask the student to carry out a particular clinical task. And I thought it was important to find out how the students feel about this particular point in the process of the day. So I'll just give you a second or two to read what the students think. Now this is obviously a very dental example, but what it boils down to, if we're looking at it from any aspect at all, is that the students are very concerned that the tutors give them tasks that they feel competent to be able to undertake and that's at the right level for their stage in the course. So based on what the student has just said and what we did on the previous slide, if you look back at the research evidence that's out there, you can see a whole list of things that are really pertinent to setting a task for a student. And first of all, what we need to do is ask the student to set the scene and give us some idea of what they're attempting to achieve today. You're not saying to them, what task are you going to do today? Because students need to be given a task. The tutor needs to step back and really think through that process of what stage is this student at in the course, what competencies have they covered prior to being set a task on a patient, and finally, how much can we push them really, I suppose, into the next stage without pushing them so far that they're not managing, if you understand my meaning. So allow them to set the scene and then gauge whether what they think they're trying to achieve is achievable for them at this stage in their course, or should they be trying to do some more. So they need to set the ground rules so that students know how far they should proceed before asking you to come and have a look and getting help and guidance. And they need to be told that, otherwise they will continue and possibly make mistakes or carry on to a point where maybe they needed to take smaller steps, let's say. They need to be explicit in what they're being told, and we need to ensure that the student has understood what's being said. And sometimes, as you know, with communication, what we say isn't exactly what's perceived by the person at the other end of hearing what you're saying. So it's really clear, really better to make sure we're clear about this. And if this actually means writing it down on paper for the students, that's what you do. We need to also understand the students' expectations and their anxieties, because they will be anxious. It's really difficult working on the public when you're used to maybe working in clinical skills or working on one another. We need to give the students plenty of opportunities to ask questions, and I think that this is really important, because what I've found is that students are not so keen to ask questions because they think they're going to come across as being unknowledgeable, unable to carry out their tasks, all these negative things, when in fact we can't expect them to know everything all the time. They have to ask us questions, and particularly if they are anxious about something. So if they're anxious and they ask a question, we don't make them more anxious by saying, why are you asking a question? We need to make sure that we're clear that it's okay to ask questions and it's okay to sort things out before you go ahead and do something wrong. On the other hand, we have to stimulate critical thinking in the student, and it may be that if a student asks a question, it's an opportunity for the tutor then to expand on that and say, well, let's have a look at this and see why we're doing what we're doing. Let's expand on it. Let's look for the evidence base behind what we're doing, and really make them be critical about the questions that they're asking and then the answers that they're being given. We need to recognise and adapt the learner's need to the level of competence, and I think that's really what the student was trying to say. Don't make me do something that's really out with my comfort zone, basically, is what they're saying. You can push me a little bit, but don't make it so hard that I'm going to fail all the time. And then we need to link the teaching to the defined course competencies, and as tutors and as clinical staff, we need to have a good understanding about what the competency is that the student's trying to achieve at this time, and then make sure that the task that we give them is going to reflect that. So when and how do we intervene during treatment? Well, obviously, if we're getting a little bit anxious, it doesn't matter what member of clinical staff you are. If you're getting anxious about the treatment that a patient's receiving, you do have to intervene. There are skills in doing this. I think that students shouldn't be given a fright. It's sometimes you do want to jump in so much that the students actually think, oh my goodness, what have I done? But there are skills in this, and I think this is something that needs to be practiced on clinic. We need to do peer review of one another on clinic, whether it be support staff or tutor staff. We need to work with one another to see what works for us, and also to get feedback from one another to find out if the way that we're approaching this is actually appropriate, or if it's detrimental both to the student and to the patient. We need to grade. We don't have an option in this. We need to record what the students' achievements have been during the times that they've been on clinic. They need to build up a portfolio of evidence that they've actually manage to reach their competency level. So we do have to do it, but how we grade is the big question. And you can see from the students' comments here that what they need is a standardised approach to their grading of their assessments. That is the fundamental, most important point about grading a student, is that it should be standardised. The assessment criteria has to be clear, everybody has to be following it, and everybody has to be following it in the same way. And that is probably the most important part about what it is we're trying to do. And if a tutor's unclear or a nurse is unclear about what the standard is that they should be grading against, they need to have a discussion with another member of staff and then come to some decision. We do this a lot when we do peer reviews, when the tutors and the staff mix up a wee bit and double mark and check to make sure that the gradings are being given appropriately. And this is a really important aspect of what we do. So there are times, and there should be times, that are allocated for double marking, whether it be with nursing staff or tutor staff, to ensure that this is calibrated and that it is all being used in exactly the same way. It's very important. In the same way that the briefing sessions at the beginning of a clinical session were really important as far as I'm concerned, I think that debriefing sessions at the end are even more important. This isn't just myself saying this, you'll see that it's there from research papers as well, and they're saying that post-clinical conferences, they're calling them, were essential to student learning. So I don't think it's something that we can miss out. If people are saying that these are really important, we really ought to be doing them. Again, they were saying that 90% of participants agreed that post-clinical conferences influenced their learning. So I think to let a student just leave at the end of a clinic, just having been given the grade, is probably not the best way. I think getting them all together to discuss what's actually happened to them on the clinic that day, because they'll all have different experiences, is really important. They can learn from one another, and they can understand that the difficulties that they're having, everybody else is having as well, because often students will say things like, everybody else is managing better than I am, or I'm being left behind, or everybody else gets better grades than me. And I think that this debriefing session is the one thing that takes that away, because they look round at the others and think, oh, you had the same problem as well, and well, your patient reacted in that way, oh, I found that too. And all of a sudden these worries, these anxieties disappear, and they can sort them out, they can discuss them quite clearly with a tutor and with members of staff present, so that they can guide what they're saying and reassure them that everything is actually okay. And these debriefing sessions, I think, are probably one of the most important things that we can do at the end of a clinical session, to allow the student to leave on a high, with a better understanding of what's happened to them, and also the ability to then go and reflect much more positively maybe than they would have done if they were going away with their own thoughts in their head and not having been able to express any of this. Wilson says the ability to learn from clinical experiences and use them to improve their future practice is an essential skill. Teachers can stimulate this process by creating a non-judgmental atmosphere with opportunities for verbal briefing and debriefing of eventual circumstances and feelings and correct misunderstandings. It is such a powerful session to be able to do with students, and everybody should be involved in this. Group feedback sessions in which members are able to question each other can provide suggestions and helpful advice for future clinical episodes. It's really a good thing to do, and we really need to be sure that we are doing this. We could question how much we should be involving the patient in all of this, and I'm not suggesting that the patients are held back in order that they can be involved in the debriefing session, because it really is about the student experience and how they compare to the other students having the same sort of experience. But if we do try to involve the patient in what's happening in not only their care, obviously, but in the student's assessment, then one of the main points that we have to remember is that being scolded in front of patients was cited as an example of a negative experience, and I would suggest that that's maybe just an understatement. We can, however, use the patient's feedback for 360 feedback, which is a really important tool for students as well, to find out not only what they felt about it in their own reflection, what the tutors felt about it in the grading that they've been given, but also what the patient felt about it from being treated by them and how they were treated by them. And as I'll come on to in a minute or two, the support staff input into that 360 feedback too. There's some comments there again from the students, so I'll leave you to read that. I've just mentioned that it's important to involve the support staff in this feedback process, and the reason I say that is that the nurses are generally with the students all the time, while the tutors might be moving between one student and another, so they get to see the whole treatment session that the student's undertaking. So for that reason, I think they should be involved in this feedback process formally. A lot of the time we do it informally, but I think that these days it's more important that it becomes a formal written process, and that we do actually have a record of what the nurses have felt about what the student's been doing. I would suggest that this should form part of the 360 feedback process that we've been describing. And some of the reasons for this include not only finding out what's happened during the session when the tutor wasn't there, but also that it promotes team teaching, it promotes respect for other members of the team, it gives another perspective on the student's achievement, and it should contribute to the overall grade achieved by the student in that session. I hope you would agree. When we look at feedback, we can look at good forms of feedback and poor forms of feedback. So I've gone back to research again to find out what the authors are saying about good forms of feedback. And it seems that if a student is given practical tips on how to solve the problems that they have, they really appreciate that. They need specific feedback. They need information about the errors that they're making, but it needs to be specific so that they can work on it. Students who make mistakes or repeated errors, they have the potential to improve, and it's important that we make sure that they understand where the mistakes are so that they can improve. Satisfactory and unsatisfactory aspects of an outcome is considered to be informative. They need to know if it's unsatisfactory and need to know what is satisfactory. I think that that all makes perfect sense, but the point is that it needs to be specific. And the students, of course, will learn from their own mistakes, and I'm quite sure that we can remember times when we've thought to ourselves, well, I won't do that again. And that's what happens with students. So we need to inform them when things aren't right, and there's no reason for saying that they are right if they're not. If we look at what the poor forms of feedback are, it seems that non-specific feedback and feedback that focus on mistakes but not on how to improve are a big problem. So this is recognised. Specific and really practical is what the students are looking for. Ask the students to make some comments about the difference from being in the clinical skills lab to being in the clinic. And while the biggest difference is that there are patients in the clinic and there aren't any in clinical skills, I thought it was interesting to see that there is a change in atmosphere, and it would be very nice if we could take the relaxed atmosphere of the clinical skills lab onto the clinic and use that there. But the students' comments are interesting, so I'll let you have a read of those. Now that we've looked at the process of how and when we intervene with students when they're with patients in the clinic, it becomes the point at which we need to look at this interaction between the tutor and the student. And I've called it tutor-student conduct in clinical teaching and assessment. However, that sounds a wee bit dramatic. But when you look at the research that's out there about how much this influences what happens to students on the clinic, it is something that I do think we have to take quite seriously. So I've summarised all the research that I've been reading, and I've popped it into good and poor relationship between student and tutor. So on the good side, it's great. We would love to reflect the clinical skills atmosphere. I'm not quite sure how easy that is to do when we've got patients on the clinic, but I think it's something that we need to reflect on and think, well, how can we make that the same on the clinic and maintain the professionalism? So we need to create an environment that is conducive to learning and not stressful, like the student mentioned in the previous slide. We need, however, to still intellectually challenge the students and maintain a supportive attitude. We do need to push them, and it's about working out where that push becomes a shove, I suppose, really is what I'm trying to say. Looking at the poor side of things, and this is probably the more serious and the more unfortunate side of when things go wrong. But if we look at the impact of poor role modelling on medical students, professionals and personal development on the basis of one singular one singular incident that happened to them, one thing went wrong and it's affected everything that they've done on the clinic ever since. The students themselves have a fear of negative consequences for themselves, preventing them from seeking help from other tutors. And they tend to feel ashamed about their experiences. It seems such a shame that they should feel this way because of just one thing that's gone wrong. However, you can imagine how much worse it would be if a few things, one after the other, that had gone wrong. And another here, poor relationships between students and tutors have a negative impact. That I think we can understand, but when you look at the list of the negative impact that it can have on students, it's really quite unsettling because they feel embarrassment, fear, unhappiness, frustration and anger. And these are all fairly strong words, and I think we need to be very clear that we're trying very hard to avoid making students feel like this at all. However, this is all in research, and I'm sure we can think of some examples ourselves when we've been in the situation ourselves and felt this way, or when we've seen students who've maybe been reacting this way too. We'll just look at some final thoughts here now, and this is about role modelling. It's about how the students perceive us on the clinic and how they role model against us. I've chosen a paper just to emphasise how this can go so badly wrong. If we look at this paper, which was done in 2014, they were looking at the ethical behaviour of members of staff, and the students reported that in 61% they had witnessed unethical behaviour by medical team members at least once, and 38% stated displeasure with their personal ethical development. So if the students are, and these are really unfortunate numbers here, but I assume that what's happened is that because they were seeing unethical behaviour, they then weren't able to role model good ethical behaviour, so they perceived that their ethical development wasn't as good as it should have been because they didn't have role models to follow. This is really just a matter of fact from a paper, but I think it's really relevant for us to remember that the students are watching us all the time to try and emulate our good practice. If we look at what happens on clinics that are very good for students, student nurses who are exposed to a caring attitude and environment are far more likely to reflect these characteristics when they become registered nurses. So that's what we want. We want them to be in a caring environment and to give a caring attitude. And I think that this list of characteristics are really what we're trying to get from our students and that we need to then role model for them. I suggest it's empathy. It's about being constructive and telling them about what they do need to do, giving good feed forward, being supportive of them when things are going well and also when things are not going so well, being non-confrontational. If a student isn't willing to take on board the feedback that they're being given, they need to be given time in order to do that and then come back to it again after reflection. They need to maintain standards. Our professional bodies require this of us, whether it be the General Dental Council or the General Medical Council. So we have to maintain these standards, and it's all about professionalism. Professionalism is a really difficult thing to try and teach, but that's what we're trying to get across to students by our own role modelling. And I suppose finally, just to mention, I suppose that we do have to think back ourselves sometimes and remember what it actually felt like to be a student and try and put ourselves in their shoes sometimes just to see how what we're doing is affecting them. Thank you.